Thank you so much, Filippo. Thank you for accepting this invitation. We are honored. Thank you so much, Filippo, and let's get started with your conference.
Thank you, and it's my honor and privilege to deliver this online webinar. We slightly changed an agreement with one from diastolic dysfunction in sepsis to a broader discussion on diastolic dysfunction in the critically ill patient. Why the slide is not moving? Okay, yeah, perfect. So in the summary, what we will go through what is the definition and diagnosis of LV diastolic dysfunction, its impact a bit in the perioperative setting, and then we will focus mainly on the impact in the ICU, which is I'm sure what you are more interested, and some suggestion on how to deal and how to optimize the patient with LV diastolic dysfunction. So for ages, we have been focusing on a number, LV ejection fraction, which roughly tell us information about systole, but it's not only about squeezing blood through the heart into the systemic circulation, but it's also about relaxation, because a ventricle that can't feel well, of course, can't eject very well, so the stroke volume will go down. We now know that diastole is an ATP-dependent process, is an energy-dependent process. And indeed, during ischemia, the patient has got impairment of diastolic function even earlier than the systolic impairment. So that's important. And when we talk about diastology and the study of diastolic function, I tend to ask my trainees what is their definition of diastolic function, and I tell you that most of them really struggle with that because it's easy to define systolic function by saying a magic number of ejection fraction. Is a bit more complex of diastolic function. And I would say that a normal diastolic function is in condition when we have a filling of the left ventricle that happens despite low left atrial pressure and therefore a low left atrial to LV gradient. Therefore, we will have low LV and diastolic pressure. What happened in diastolic dysfunction is that this is taken from the most recent guidelines, this definition. We have an impaired relaxation and increased stiffness of the LV, which finally ends up in LV and diastolic pressure, which becomes higher. I want to do a premise on diastolic dysfunction. Please do not confound with diastolic failure, because diastolic dysfunction is an echocardiographic finding which you make after you are trained in echocardiography and you are able to interpret several parameters. While diastolic heart failure is a different thing, is a scenario of heart failure with symptoms of heart failure in presence of a normal LV ejection fraction and normal mitral valve apparatus. So we will move during this talk from the physiology of diastolic dysfunction to the recommendation recently published for the assessment. And finally, we will move on the more interesting part. As you can see, the baby is now smiling on understanding the clinical relevance, because I think we are all clinicians interested in what is the clinical relevance or what we do in order to do something better for our patients. So let's talk about the physiology. You are all familiar with that, and you know that during this phase, before the ejection, the left ventricle pressure rises up, and when it becomes higher than the pressure into the aorta, then the aortic valve opens. There is the ejection of blood through the aortic valve, which goes in the systemic circulation. And when the pressure in the left ventricle drops below the aorta, then the aortic valve closes. And now we start diastole. With a relaxation, you can see this line, relaxation of the ventricle, and the steeper is this relaxation, the better is the diastolic function, and the chamber are less stiff. So during this phase, which we know is the isovolumetric relaxation time, the heart relaxes. And finally, when the pressure in the left ventricle drops below the left atrium, then we have an opening of the mitral valve and the early filling starts. And this is in normal condition dominant as compared to the atrial feeling, which happens when the atrium contracts. But before that, you can see that the feeling of the left ventricle brings the pressure higher than in the left atrium, and therefore the mitral valve tends to close. And then the atrial contraction increases the pressure in the left atrium, and the mitral valve opens, and there is the second part of the feeling in patient with sinus rhythm. As you can see, this is the ECG plot, and which is plotted here, and the P wave in correspondence of the atrial feeling. So in a normal diastolic function patient, we have a dominant early feeling in the transmitral blood flow. I'm sure you are all familiar with that. This is a transesophageal imaging. Now let's look at the left part of the figure here. This is taken from the new recommendation of the assessment of the LV diastolic function, the European and American joint recommendation. And you see they look pretty much similar, but this is in normal end diastolic pressure condition, and this is high end diastolic pressure condition. Because what is different is the scale here. This ventricle is normal, and the pressure drops at the end of systole, and when diastole begins, roughly to 5 millimeters of mercury, while in the ventricle that has got high end diastolic pressure, the pressure drops to 10, is unable to relax well, and is a bit stiffer, and therefore pressure doesn't drop to a normal level, so to 5. And if you look this area that I look here with the arrow, it's smaller than this area. So now when we move in this part of the figure on the right hand side, we see what means normal ejection, relaxation, and then we move in a condition where the ventricle becomes stiffer, the curve is less steep in the relaxation, and therefore the early feeling decreases. You see how smaller is this than this E wave, and the atrial feeling becomes bigger. You see that this part, I hope you can follow nicely the arrow, here is bigger than here. Now the next step is what is an adaptation from our body, and basically what it is about an increase in LA pressure, which is higher now, and this restores the gradient between the left atrium and the left ventricle. We have an E wave which is bigger than the A wave, but this happens at the expenses of high LA pressure, and we call it pseudo-normalization because it looks normal but is not normal. I let you watch this video on the progression of diastolic dysfunction. I think this video is very nice. It shows how the EA ratio changes according to the LV-LA pressure when we move to abnormal relaxation, and then finally to pseudo-normal, and then to the third degree, which is restrictive. Now I let you watch another time for this video. And now we are moving to the restrictive, when the pressure in the LV are very high, and even a tiny amount of blood brings up the pressure consistently. Indeed, if you see here, the E wave becomes even bigger than the A wave because the atrial contraction can't fill the ventricle, because the ventricle has got so high end diastolic pressure that it can be filled even with atrial contraction, active atrial contraction. Now, it would be nice if it's that easy, but it's not that easy. And for instance, age, heart rate, presence of heart valve disease, all these things can influence the diastolic function and the evaluation. This, for instance, is an evaluation that you can see in a patient according to age. And you see how the EA ratio becomes half between young adolescent and going to people older than 60. Same with the E prime value that changes and diminishes a lot. So age is one concern, but even the same patient put under stress, so going to do exercise, there are lots of changes in most of the variables. Only the EE prime ratio looks pretty much the same if the patient has got normal heart function, but the other parameters change significantly. And this is because the heart rate during exercise increases. And you know that tachycardia allows for shorter passive feeling, therefore there is a reduced E wave, while bradycardia allows longer diastolic time, longer passive feeling, increased E wave. And also, with regards to heart rate, you can see a clot in the left atrial appendage here in 3D, here in a 2D zoom image in transesophageal. When you have atrial fibrillation, the EA ratio is not anymore there because you don't have an atrial contraction, so you can't evaluate EA. And finally, moving to heart valve disease, it's difficult to evaluate transmitral blood flow in presence of such mitral valve stenosis. This is a 3D view from the left ventricle. It's difficult to evaluate the transmitral blood flow in condition of mitral regurgitation, aortic regurgitation, etc. So it's not that easy, and someone may get confused, lost, or whatever. But the new recommendation provides some help. But let's see before the new recommendation where we were up to a few months ago, a year ago, roughly, we were with the 2009 guidelines, where this was a kind of practical approach to grade diastolic dysfunction. And despite this practical approach, there are a lot of parameters in here to evaluate the degree of diastolic dysfunction. And the problem was that lots of patients still remain with indeterminate diastolic function. This is a very important point, that we were not able to define what was the normal the diastolic function normal, or what was the degree of dysfunction in several patients. The new guidelines published in July 2016, if I'm not wrong, are very interesting in this regard, because they help us by recommending, in most cases, only 4 variables for the diagnosis of LV diastolic dysfunction. So the 4 variables are the following one, and you see the first 2 are TDI-derived variables, so tissue Doppler imaging. We will talk a bit about these 2 variables. And then we have the left atrial volume index and the tricuspid regurgitation peak velocity. When we look at what are the abnormal values to diagnose the LV diastolic dysfunction, we see that E prime myocardial velocity at annular level below 7 centimeters per second in septal and below 10 at lateral level is 1 point. Similar for the E prime ratio, which on average more than 14 or more than 15 if we use E prime from septal level, and more than 13 if we use E prime from lateral level. And then LA volume index more than 34 mL per meter square of BSA, body surface area, or a tricuspid regurgitation peak velocity of 2.8 or more meters per second, which translate in a gradient between the right atrium and the right ventricle of roughly 32 millimeters of mercury. So what happened in the grading of diastolic dysfunction is that the relaxation of the LV is impaired in all the cases of diastolic dysfunction, while the left atrial pressure starts to be elevated only on grade 2. All the other 4 parameters that are used for the evaluation of diastolic dysfunction are listed here, but of course they may not always match. So for doing diastolic dysfunction diagnosis in patients with normal ejection fraction, we use these 4 parameters, and we use this approach. If less than 50% are positive, we have normal diastolic function. If more than 50% are positive, we have diastolic dysfunction. While if 50% are positive, we stay in the indeterminate diastolic function condition. One very big change, and please keep this in mind, is that with the new guidelines, the authors state that if a patient has got abnormal LV ejection fraction, by definition, there is diastolic dysfunction. So all the patients with, let's say, 45% ejection fraction will have diagnosed diastolic dysfunction, and then we have to move to grading. With regards with the grading, is pretty much simple. We use the same variables, and then we use EA ratio and E wave peak velocity. This is taken from a paper by the group of Sam Ordy and Stephen Wang, recently published in Annals of Intensive Care, but basically is easier than it was before. I'm not going through that because it requires training and everybody should study it and so on. I'm going to show the impact of these new guidelines on the diagnosis of diastolic dysfunction and on the grading in the general population. This paper by a Portuguese group is very interesting. It's published in the European Heart Journal. And what the authors did, it is a retrospective study, so with some limitation for its design, but they studied the prevalence of LV diastolic dysfunction in 1,000 of people with 45 years or older than that. And it is striking, really striking to find that with the new guidelines, we have 1% of patients, 1 to 2% of patients with diastolic dysfunction, while with the previous guidelines, the same patient, we had 38.1% patient with diastolic dysfunction. And as you expect, they found really poor concordance between guidelines. However, even more interestingly, the paper I mentioned before by the group of Tony McLean, Sam Ordy, and Stephen Wang compared in patients with sepsis and septic shock the application of 2016 guidelines with the one of 2009. And what they found, they did this evaluation on day 1 and on day 3. So if you look at the number of patients, at the percentage of patients with indeterminate diastolic dysfunction, certainly the new guidelines are able to decrease significantly the amount of patients with indeterminate diastolic dysfunction. Which of course translate in an increase of patients with diastolic dysfunction and increase of patients with normal diastolic function, because it's just a distribution of this 50 to 60% of patients that were indeterminate with the previous guidelines. I find this paper very interesting. It's open access. This is taken from the paper itself. You can look in PI. I just put here in table. I recommend reading this nice paper. Now, let's go back on the first chapter of the new guidelines. What they say. They say the guidelines are not necessarily applicable to children or in the perioperative setting. I would argue that they should have written about critical ill patients, which is even more complicated than the perioperative setting. Why? Because if I put again the 4 recommended variables, and we think about using the left atrial volume and the tricuspid regurgitation jet in patients undergoing mechanical ventilation, large fluid shift, inotropes and vasopressors, like our septic patient, can we really use them? For instance, PEEP and high intrathoracic pressure will cause a certain impairment of the right ventricle. The right ventricle can dilate. It can make worse the LV filling for that. In patients with large fluid shift, are we sure that the TR jet velocity is the same in condition of severe hypovolemia? Are we sure the LA volume doesn't change a bit? And also the use of vasopressor, inotropes. So basically, there is a quite significant difficulty nowadays in echocardiography because we use parameters that are derived by the outpatient clinic, where the patient, even with some difficulty in some case, let's say heart failure patient, they walk to the cardiology ambulatory and they have their own transthoracic echocardiography. And we want to compare these values with the one in a patient that is septic. that's really difficult. So the other two parameters are probably more reliable, but of course they are influenced less by loading condition. We know that the tissue Doppler imaging is less influenced by loading condition, but we don't know the action of inotropes, vasopressors, of their dose, how can modify the tissue Doppler imaging. Now, this is taken from the British Society of Echocardiography, but just to show that the behavior of E prime A prime ratio is different from what happened to the EA ratio, because here we have a pseudo-normalization of the pattern, while in the case of tissue Doppler imaging, the EA ratio keeps decreasing, and the E prime becomes smaller and smaller and smaller the more is affected the LV relaxation. For those of you that are not familiar with tissue Doppler imaging, what this echocardiography approach does is to evaluate with pulse wave Doppler the myocardial motion. This is a transesophageal image where we see the myocardial motion is investigated at the mitral annulus level, and is investigated with a low velocity and high amplitude signal, because the myocardial velocity is lower than the blood flow velocity and it's got higher amplitude. And what we see that during systole there is a contraction that goes from the base to the apex, while in diastole we have a movement from the apex towards the base. So in the case of transesophageal echo, it will be the opposite in transthoracic. You will have a positive E prime and A prime and a negative S prime, which is the systolic tissue Doppler imaging. And the easy stuff is that you have to remember just few numbers, that a normal diastolic function happens in condition of E prime more than A prime, that the average E prime is roughly more than 8.5, and the E prime ratio is below 8, like in the case is shown here in cardiac theater, where we have a septal E prime of 10.5 and a E prime ratio of 7.1. Okay. Let's move to the more interesting part probably of the talk, at least the one I like more, where we will find studies evaluating diastology and patient outcome. I think before moving to the critically ill and the perioperative period, we have to show some paper on the general population. And I find very interesting these three papers. They all come from quite important journal, New England, JAMA. So the first paper by Gandhi show how up to 50% of patients presenting in emergency department with pulmonary edema, they have got preserved LV ejection fraction and a normal mitral valve. So the reason for pulmonary edema is a precipitation of diastolic function. And similarly, 50% of acute heart failure hospitalization have normal ejection fraction. And interestingly, in the paper from Redfield, LV diastolic dysfunction in the general population was 4 to 5 times higher than LV systolic dysfunction. And more than half of the patients with heart failure within this large population that was studied had preserved ejection fraction. So now let's look at the perioperative period. In the perioperative period, I'm sure no one will be surprised that LV diastolic dysfunction is predictive of difficult weaning from cardiopulmonary bypass and inotrope requirement in cardiac surgery. But I can tell you more: longer length of stay in the ICU, in hospital, higher mortality, etc., etc. Similarly, in vascular surgery, open vascular surgery, is predictive, diastolic dysfunction is predictive of heart failure, prolonged hospital stay, short and long-term cardiovascular events. So it seems to matter. Now the question is if it matters for the patient with some degree of cardiac comorbidities undergoing non-cardiac, non-vascular surgery. Unfortunately, we have just few studies because it's difficult to do echocardiography in the OR. Maybe you got less anesthesiologists trained with echocardiography, less interested, maybe not a machine readily available in the operating room, etc. But I find interesting this paper by Cabrera, Schulmeier, and Ariaza. They found that in patients undergoing abdominal, orthopedic, and urological surgery, they stratified the patient according to the EE prime ratio, which is a surrogate of left atrial pressure. And this group has normal EE prime. This group is in the gray zone, and this group is really in a bad zone with EE prime. And the group with higher EE prime ratio has got an increase of pulmonary edema at 24 and 48 hours. It's got higher incidence of arrhythmias, higher risk of death, higher ICU days, and higher length of stay in hospital. And there are also some changes which are seen also in the people in the gray, in the patient in the gray area, like increase in pulmonary edema in the second day, increased arrhythmias, and increased length of stay both in hospital and in the ICU. So my answer to the question, if the diastolic function in the perioperative setting matters, is yes. Of course, the more challenging is the surgery and the more sick is the patient, the more you should take care of it. Let's move on the part which will match more your interest, which is the one on critically ill patient. And I will talk mainly about sepsis and the weaning of, from the ventilator. So sepsis and LV function or dysfunction, as you like. We now know that sepsis is not only about vasoplegia, and that despite high cardiac output in most of the patients, we have myocardial dysfunction, as you can see in by longitudinal strain echocardiography, and there are quite decent number of papers coming out on this topic. With regard to septic cardiomyopathy, there are lots of review. I'm not going to talk too much about what is the mitochondrial dysfunction, the cytokines, the histones, and whatever. But I want to show this interesting animal study by the group of Alexander Mebaza, where they showed that in rabbits treated with endotoxin, the pressure volume analysis showed not only some impairment of systolic function, but that all the indexes of diastolic function were worse. So they showed 100% worsening in diastolic function in rabbits treated with endotoxin and therefore brought to septic shock. Now, let's look at the outcome. This is the meta-analysis that prompted my studies, and I'm really grateful to Stephen for bringing more light on this topic. And what the group of Stephen Wang did is to look for ventricular dysfunction or dilatation, and to look whether there was an association with mortality in severe sepsis and septic shock. And they included 11 studies with over 700 patients for LV function, while data on RV function were a bit lower, half of the studies, 400 patients roughly. What they found no association between LV systolic function and mortality, and similarly for the RV systolic function. But I find very interesting that the p-value is low, and the forest plot almost crosses the midline because it favors survival in patients with worse LV function. So it seems that worse LV function seems better for patients. But probably this is because the problem is in how we evaluate systolic function, because LV ejection fraction, for its geometrical assumption, for its load dependency, is not probably the best parameters. However, until we will evaluate LV systolic dysfunction with ejection fraction, we can say that probably is not associated with mortality. And in this regard, the paper from Joseph Paonessa compared patients with hyperdynamic LV ejection fraction, so with those with more than 70% ejection fraction, versus those with normal ejection fraction, which was defined as 55 to 70%. And this was done not in septic, but generally in the intensive care unit. There were both sepsis and non-sepsis patients. The prevalence was roughly 8 to 9%, so 1 in 11 patients got that. And the important finding of the study is that hyperdynamic LV ejection fraction is significantly associated with mortality at 28 days, that it seems the stronger predictor in the multivariable logistic regression analysis, you see, with an odds ratio of 1.4 almost. So this is very interesting. But ejection fraction